Not too many questions have been asked in the exam from this particular topic, and whatever questions have been asked have been fairly easy. दो या तीन टॉपिक आपको एग्जाम के लिए मैंडेटरी हैं जो आपको पढ़ के जाने हैं. द फर्स्ट वन हैपेंस टू बी लंग ट्यूमर्स, which is extremely important topic. The second one that you have to remember for the exam is going to be something like ARDS, adult respiratory distress syndrome. And the third one is going to be a miscellaneous thing. The questions have been asked in the exam on a topic like pneumoconiosis, which is the example of an easy topic, right? Now, starting our discussion on the respiratory system. So, we are looking at an image of a patient who's going to be suffering from an obstructive lung disorder. And this kind of an obstructive lung disorder, as most of you should be able to pick up over here in the exam, is going to be emphysema. Right? You have two types of emphysema. The one in which you are going to be having the involvement of central part of the acinus. So, this is what is going to be called as a centriacinar emphysema. Right? The second one is what is going to be given the name of a pan-acinar emphysema. Let's have a quick recap about the important feature of both of them. Whenever we're going to be talking about centriacinar emphysema, it is going to be causing involvement of the proximal part of the acinus, and this condition is going to be associated with the sparing of the alveoli. That's very rightly said. It's a condition that is going to be predominantly causing involvement of the upper lobes of the lung, and the commonest reason for development of this kind of a condition is the patient is having a history of smoking. The second important reason apart from a smoker because of which a patient is going to be having centriacinar emphysema is because of the polluted air that he's breathing, bad AQI air, and that is going to be a patient who's going to be residing in a big city. So that's a peril or a drawback of residing in a big city. When we are talking about pan-acinar emphysema, you are going to be having the patient who's going to be having the involvement of the bilateral involvement, and there is a lower lobe or a basal involvement. This is something which is going to be associated with a patient who's going to be suffering from alpha-1 antitrypsin deficiency. So you got a question in the exam in the 2024 exam as well. Patient is going to be having alpha-1 antitrypsin deficiency. He is going to be having pan-acinar emphysema. He's also going to be having a high risk of development of micronodular cirrhosis. So that is going to be other trouble in this patient, right? When we are talking about emphysema, the clinical presentation of a patient is going to be classically an elderly male smoker individual who is going to be having a thin and a lean build. He is going to be a patient who's going to be having the chief complaint of a dry cough, right? And whenever we are going to be talking about a patient who's going to be having emphysema, he's going to be having a very severe weight loss as well. So he appears cachectic. He's an elderly male smoker. He's going to be having a severe loss of appetite as well. And these patients, however, in spite of their physical appearance, they are still going to maintain their oxygen level till the very last stage. That's why they're going to be having the term as pink puffers, right? So that's an important thing that is to be kept in mind. So basically, with that is what you need to regard emphysema. And as I just made a mention, the part of the respiratory tree that is affected in these patients happens to be acinus, right? Of course, the patients are going to be having at times the development of a trapping of the lungs because they cannot expire all the air out. So they are going to be having the presence of increase in the enteroposterior diameter of the chest. So that is what is going to be associated with the term barrel chest, right? Why do we need to talk about this condition is because these patients are always at high risk for development of pulmonary hypertension. And all of you know the fact, I mean, if a patient is having pulmonary hypertension, then this is going to be responsible for increasing the risk of right-sided heart failure. That's given the name of cor pulmonale. Why is cor pulmonale important? Because that causes death of the patient. So patients having obstructive lung disorders, they die because of right-sided cardiac failure. That's what is to be kept in mind. Once we are aware of this particular fact, then the next thing that we need to remember in the exams is going to be chronic bronchitis. Chronic bronchitis, as we all of you are aware, is a clinical definition of a patient who is going to be having presence of productive cough. He is continuously coughing and sputum comes out for a duration of at least 3 months in 2 consecutive years. Why that takes place is because the patient is going to be having an infection. And because of the infection, the patients are going to be having the development of not only cough, there is also difficulty in breathing. Because of the infection, the patients are going to be having increase in the mucus production. And increased mucus production is going to be associated with increase in the thickness of the mucous gland layer. The increase in thickness of the mucous gland layer is something that you can make out with the help of an index that is given the name of Reed's index. Bronchitis patients have got a relatively uncommon but a very important problem that these patients can be having over many years progression into development of cancer. There is a high risk of development of bronchogenic carcinoma in a patient who's going to be having chronic bronchitis simply because of development of squamous metaplasia. What you need to remember over here is chronic bronchitis patients are not going to be having amyloidosis. So जितनी भी inflammatory conditions होती हैं, all chronic inflammatory conditions, they typically have amyloidosis, but chronic bronchitis is an exception. It is not going to be having amyloidosis over here. That's what you need to remember over here. When we are talking about chronic bronchitis, patients are going to be sometimes given another important name. They are going to be given the name of blue bloaters. So this patient is going to be a patient in the age group of 50 to 70 years. Again, he's going to be having cough with sputum, and he's going to be having a high risk of development of discoloration of his body because of cyanosis, increase in the thickness of the mucous gland layer. That's the other important thing that you need to remember. Both emphysema as well as chronic bronchitis are example of obstructive lung disorders. So they are going to be classified together as an example of COPD. And when we are talking about COPD, we have a set of guidelines. That's a medicine question. That's what you need to remember over here. That's going to be associated with the GINA guidelines, right? So sorry, the gold guidelines. GINA guidelines is for asthma. Gold guidelines is what we are talking about over here. Nasal amyloidosis is not seen over here. सर ने आपको ठीक बताया होगा, आप एक बार वीडियो को दोबारा देख लेना. Third one that we need to talk about over here is a patient who's going to be suffering from asthma. Asthma, most of the times, is an example of an extrinsic asthma. Extrinsic asthma means the patient is going to be having an intake of a substance. Say, for example, the exposure to pollen grains. Say, for example, house dust particle. As a result of which the patient is going to be having a type 1 hypersensitivity reaction. There is more release of leukotrienes. Because of leukotrienes, patients are going to be having bronchospasm, and that's why there is going to be a difficulty in breathing. There are two phases of asthma that we talk about. One is the early phase, second is the late phase. In the early phase, patients are going to be having the role played by histamine. There is a role played by mast cell. There is a role played by prostaglandins, and there is a role played by leukotrienes. Remember the fact that when we are talking about cells like eosinophils, cells like neutrophils, they are going to be important, but they are important only in the late phase of asthma. So that was what was asked to you as an INI question. Whenever we are going to be talking about the other type of asthma that is given the name of intrinsic asthma can be seen in people having a history of viral infection. There can be a situation when the patient has been exposed to cold temperature. So swimming करने जा रहा है आदमी cold water के अंदर, or he is going to be running in a cold weather, or that can be seen because of an individual taking certain types of drugs. Example of such a drug that you need to remember over here is NSAID, especially a drug like aspirin. The other drug that you need to remember is ibuprofen. With regards to aspirin, you are asked a question in the exam about a triad. The triad is what is going to be given the name of Samter's triad. Whenever we are talking about asthma, the problem that we have in these patients, that microscopically patients are going to be having lots of eosinophils in their airways. These patients are going to be having more deposition of collagen in their airways. These patients are going to be having an increase in the size of the smooth muscles. Smooth muscles are going to be having an increase in their size. And what is going to be seen in these patients is that there is a development of subepithelial fibrosis. So it is very much expected that all these things together are given the name of airway remodeling. Now, airway remodeling can be a potential NEET PG question. Airway remodeling is a potential NEET PG question, but the components of airway remodeling is going to be an example of an INI question. So four changes that you see in case of airway remodeling: subepithelial fibrosis. There is more deposition of collagen over here. The smooth muscles are going to increase in size. That means smooth muscle hypertrophy. And what you're going to be observing in these patients is eosinophilic infiltration. So four components. Typically an example of a question जहाँ पे वो बोलते हैं आपको A and B are correct, A, B, C are correct, A, B, C, D is correct. That is a kind of question that you need to remember, for which this can be asked in the exam. Very old facts, but they are not likely to be given in the exam. So I don't care if you are not able to recall these images. But in the sputum of a patient having asthma, you can be having the presence of Crayola bodies. Crayola bodies are going to be degenerated airway epithelial cells. You can be having the presence of needle-like crystals, which are given the name of Charcot-Leyden crystals. Or you could be having the presence of spiral-like structures, as you can make out over here. This is given the name of Kirschmann spiral. So Crayola body, Kirschmann spiral, and the presence of Charcot-Leyden crystals. These are the three C's classically associated with asthma. Nowadays, we are not going to be asked questions on this. What we can be asked a question in the exam is that we have identified certain molecular markers by which we can predict the severity of asthma. That is pretty much given in your notes as well, which is given the name of YKL40. The second thing that you need to remember regarding asthma is going to be the example of drugs which are going to be given. So we are going to be using guidelines which are going to be given the name of GINA guidelines. And of course, as per the GINA guidelines, most of you are familiar that two important drugs are going to be very useful for treatment of patient having asthma. One is corticosteroids and the second are going to be beta-2 agonists. Amongst the beta-2 agonists, the first drug that is to be preferred nowadays as per the guidelines happens to be formoterol. So far as the steroids are concerned, of course, you are going to be giving these patients drugs like budesonide, right? There is an example of a steroid that is very, very likely to be asked in the exam, especially the INA exam. That is what is going to be given the name of a soft steroid. The drug that you associate with the term soft steroid is going to be given the name of Shea-Sebum Veriride Cyclesonide, right? So this particular drug is going to be having its active metabolite, which is produced inside the airway and the lungs only, and therefore it is going to be having lesser chances of causing systemic side effects. A patient who is going to be having taking inhaler, meter dose inhalers are the pumps that you see, which is going to be used by the patients. So especially when the patient is going to be taking inhalational steroids, there is a high risk of development of local immunosuppression in the oral cavity that can be responsible for increasing the risk of development of candidiasis. The best way to prevent candidiasis, mark my words, best way to prevent candidiasis is the patient should do a oral gargling or a mouthwash. In case that is still not able to prevent the oral candidiasis, what the patient is going to be doing is a mouthwash with an antifungal drug. The antifungal drug that the patient is going to be using is nystatin. So nystatin mouthwash is what is recommended for the patients. Now imagine a situation when the patient has taken steroids and suppose even nystatin is not able to work properly in these patients, then for candidiasis, you are going to be giving a drug. That's a pharmacology question. The drug of choice for candida infection happens to be what is going to be given the name of fluconazole. Fluconazole. So yesterday we had a discussion about itraconazole that is given for the treatment of histoplasmosis. Fluconazole is a drug that is given for the treatment of a patient who's going to be having candidiasis, right? We are having an example of an antifungal drug in the azole category, which is also going to be functioning as an example of an enzyme inhibitor and can cause gynecomastia as a side effect. What is the drug I'm talking about? What's the drug I'm talking about? Azole drug, which can cause gynecomastia as a side effect. Yes, you are all aware. That's an example of a drug that is called as ketoconazole, right? So these are the important things that we can talk about with in respect of a patient who's going to be having asthma. Then we are going to be talking about a patient who's going to be having bronchiectasis. Patients who are going to be having bronchiectasis are going to be having dilatation of the airways. Dilatation of the airways are going to be seen in the patient. And this kind of a dilatation of the airways is unfortunately example of a permanent dilatation. Now, what is going to be seen in these patients is typically the patients are going to be having a history of infections, or the patient is going to be having some kind of an obstruction, infection or some kind of an obstruction. The classical risk factors which are going to be seen, especially in country like ours, is going to be one can be tuberculosis, another can be a patient who's going to be having the presence of foreign body, another can be aspergillus, another can be a patient who's going to be having a cancer. Uncommon causes, but which are going to be asked in the exams as MCQ options, can be a condition that is given the name of Carter-Jenner syndrome. This was 2022's question. Carter-Jenner syndrome is going to be an example of a condition in which the patients are going to be having a triad. The patients are going to be having a development of bronchiectasis. They are going to be having sinusitis and they are going to be having situs inversus. Yes, you are aware of it. The second condition is what is going to be asked in the exam, that is given the name of cystic fibrosis. Cystic fibrosis is a problem of chloride transporter defect. Chloride transporter defect, the patients are going to be having delta 507, delta 508. That is what is going to be having a trouble over here. 506 trouble is what is seen in case of Leader's mutation. 508 is what is seen in cystic fibrosis. So these patients are going to be having high risk of development of infections. Particularly, the patients are at high risk of development of bronchitis, high risk of development of pancreatitis, and the patients are having a high risk of development of infections caused by Pseudomonas organism. Majority of the pulmonary disorders are going to be causing involvement of right lung. Right lung. That is understandable. Anatomically, you know the fact that right airway is more in line with the trachea. So right lung is more commonly going to be affected. But what we are going to be having is bronchiectasis as an example of a condition, especially congenital bronchiectasis, which is going to be causing involvement of the left lung. Clinical history of the question which is given in the exam for a patient having bronchiectasis is that you have a patient who is sleeping, let us say in the night. When he gets up in the morning, the patient starts coughing violently. And when he is coughing, with every change in the posture, lots and lots of sputum is coming for the patient. That is given the name of bronchoria, right? So cups full of sputum on change in the posture. Mark my words, cups full of sputum on change in the posture. That is what is going to be seen in the patients. Patients could be having the presence of fever as well. Patients could be having the presence of a foul smelling which is coming from their sputum because of the infection as well, right? So these risk factors are what are important. TB is important, aspergillus is important because you are familiar with a condition called as ABPA, bronchopulmonary aspergillosis. You are familiar with Carter-Jenner syndrome, you are familiar with a condition called as cystic fibrosis. Grossly, if you see the patients, you are going to be having airways which are going to be seen in the lungs. When you want to make a diagnosis, obviously you are not going to take out the lung and make a diagnosis now. So you will be doing an examination with the help of high resolution CT scan. And once you're going to be doing a high resolution CT scan, what you get are two important findings. One, which is going to be given the name of signet ring appearance. Second is what is going to be given the name of tram track appearance. So easy for you to remember the fact, tram track appearance in the kidney biopsy is going to be a feature of MPGM, but tram track appearance on the high resolution CT scan is going to be a feature of bronchiectasis. Fact number two, tram track also appearance is also seen in case of CT scan of the brain as well. That is seen in a patient having Sturge-Weber syndrome. When we are talking about the signet ring appearance in the microscopic examination of the stomach or on the ovary is going to be a feature of cancer, Krukenbach's tumor or diffuse gastric carcinoma. But signet ring appearance that you're getting on the CT scan is going to be a finding is associated with a patient who's going to be suffering from bronchiectasis. So those are the important things that you need to remember. Of course, you would be giving mucolytic drugs, you would be giving bronchodilators, you would be giving antibiotics for these patients. Common example of a mucolytic drug that is being given practically commonly is Ambroxol. The second drug that is asked in your exam happens to be N-acetylcysteine. N-acetylcysteine is also a forensic medicine question because it is a drug that is given for the treatment of a patient having paracetamol poisoning. It is responsible for replenishment of the reduced glutathione stores in the body of a patient, right? So it is going to counter the activity of the N-acetyl para-aminobenzoquinoamine, that is NAPBQI, which is responsible for causing the hepatic damage in a patient who's going to be having the paracetamol poisoning. When we are talking about cystic fibrosis, yes, Ria, very good that you know the fact you are going to be having drugs which are going to be replacing the lost protein, which is going to be given the name of ivacaftor, right? So those are the other things that we just need to be asked, remembered in the exams. Then we are going to be talking about an example of a condition that is going to be given the name of pneumonia. I don't think I need to talk about and explain it in detail over here with two important recaps over here. This one is going to be given the name of typical pneumonia. This is also called as airspace pneumonia. What you are going to be having over here is neutrophilic infiltration. And what you are having in these patients is going to be presence of alveolar exudate. Alveolar exudate. So alveolar exudate is going to be associated in the involvement of the airspace. That is why it is going to be given the name of the typical pneumonia or the airspace pneumonia. You have four stages as per the Linux stages of pneumonia, which all of you are aware of. First is congestion. The second is going to be red hepatization. The third is going to be gray hepatization. And the fourth one happens to be resolution. So this sequence is important. Congestion, red hepatization, gray hepatization, resolution. That is what is seen. If the infection is taking place in a community setting, the likely causes are strep pneumoniae. If it is taking place within the hospital, you think in terms of something like Staph aureus, and you think in terms of an organism like Pseudomonas. Suppose the patient is having a history of staying in an ICU, then you would suspect an organism like Legionella. Suppose you have a patient having a history of, let us say, alcoholic intake, you will suspect an organism like Klebsiella. So those terms have already been given in the notes. We have talked about them in detail. Just quickly have a recap about them. Of course, I'm over here as of now ignoring the important organism like Mycobacterium tuberculosis. The other reason for development of pneumonia is again bacteria, but these bacteria are responsible for causing what is called the name of atypical pneumonia. This is also called as walking pneumonia in the patients. Instead of causing involvement of the air spaces, these patients are going to be having interstitial tissue inflammation. Interstitial tissue inflammation. Out of all the organisms over here, the most dangerous are going to be the organisms which are going to be given the name of Mycoplasma pneumoniae. Mycoplasma pneumoniae. The other organism that we need to remember over here is going to be an organism that is given the name of chlamydia. Of course, we can be talking about certain types of viruses as well, certain types of fungi as well, which are responsible for causing atypical pneumonia. In the viruses, you should be familiar with measles. So in case of measles, we are already familiar with the example of the Warthin-Finkel cell. The other one which can be causing pneumonia is going to be cytomegalovirus. Cytomegalovirus, which is going to be having the presence of an owl-eye appearance. That is what we discussed. Then we are going to be having an important reason for a virus causing trouble in case of children. Respiratory syncytial virus, for which you give a drug like ribavirin. You remember that? It causes bronchiolitis. The third example, apart from this, is going to be a patient who's going to be having fungal infections like pneumocystis. Pneumocystis yerbecae, which is responsible for causing immunocompromised individuals pneumonia. So that is going to cause pneumonia in a patient who is going to be having a history of HIV positivity. And of course, you can be having the usual causes of pneumonia like influenza virus. Dr. Bobby, I'm just talking about more of micro over here. So path points are just two. Typical pneumonia is airspace pneumonia, alveolar exudate. That's what you need to remember. Atypical pneumonia, interstitial tissue inflammation. इंटरस्टिशियल टिश्यू इन्फ्लामेशन, ठीक है, इतनी ही चीजें हमें याद रखनी है पैथ के परस्पेक्टिव से. बाकी आपको याद रखनी है जो चीज वो है ये वाली स्टेजेस ऑफ निमोनिया, कंजेशन, रेड हेपेटाइजेशन, ग्रे हेपेटाइजेशन, resolution, right? This is what we just need to talk about. Then we are going to be asked question in the exam, which is going to be with respect to, let us say, condition which is given the name of VAP, that is ventilator associated pneumonia, or we're going to be talking about a patient who is admitted in the hospital and after 48 hours he is going to be developing a pneumonia, so that is going to be given the name of nosocomial pneumonia, right? So otherwise most of you are aware already about the fact that the commonest nosocomial infection happens to be urinary tract infection, right? Whenever we are going to be talking about the other important thing, we need to be familiar with pneumoconiotic disorders. Easy questions. I just hope you are aware of the fact this is the commonest pneumoconiotic disorder, that is silicosis. Classically, what they will ask you question in the exam is who are the people at high risk for development of silicosis. So these patients are going to be people who are going to be working in a construction site, people who are going to be working in a stone quarry. Stone quarry मतलब जहाँ पे पत्थर को तोड़ा जाता है, stone quarry. People who are going to be working, let us say, in the mining, right? Or the people who are going to be working in sand blasting. Sand blasting. So glass की अगर कोई चीजें बन रही हैं, sand blasters, they are again going to be the people who are going to be having silicosis. Silica is a light dust particle, so upper lobe involvement is seen in these patients. Because of upper lobe involvement, there is always a high risk of development of tuberculosis in these patients. That is what is given the name of silicotuberculosis. All of you recall the fact, 2018's question, that the particle size which is going to be very dangerous for the patient is going to be between the range of 1 to 5 microns. X-ray appearance of these patients having silicosis, that is what is going to be associated with the term eggshell calcification. So that's again which is known to you. Any patient who's going to be having the other disorder that is asked in the exam is going to be anthracosis. Anthracosis plus rheumatoid arthritis is what we discussed yesterday as well. That is given the name of Kaplan syndrome. Majority of the patients who are going to be having anthracosis are not having any clinical symptoms. So this is asymptomatic co-workers pneumoconiosis. Over a period of time, patients are going to be having deposition of black colored pigment. So that is going to be responsible for causing black lung. Unfortunately, after 15 or 20 years of exposure, patients are going to be having a condition that is going to be given the name of progressive massive fibrosis. Progressive massive fibrosis. I hope you can recall for me what was the Ivan syndrome that we talked about yesterday. हम ऐसे ही याद रखेंगे information. Ivan syndrome किसको बोला था हमने? Ivan syndrome. Ivan syndrome very good. Autoimmune hemolytic anemia plus सीरियल के साथ में अगर ऑटो इम्यून हिमोलिटिक एनीमिया या फिर आईटीबी होता है तो उसको इवान सिंड्रोम बोलते हैं. कैप्लान सिंड्रोम इज एंथ्राकोसिस प्लस रूमेटॉइड आर्थराइटिस. Right. The other important thing that we need to recall over here is going to be with regards to, I believe, this is a very, very important thing which is asked in the exam, that is pleural plaque. Pleural plaque is the most common pulmonary manifestation of a patient who's going to be having exposure to asbestos. Asbestos. Asbestos has got multiple particles, but we need to be recalling the fact that it is amphibole, which is going to be more troublesome. Asbestos is going to be an example of a heavy dust particle. So these are the patients who are going to be involved in any kind of a work in the insulation industry. So waterproofing, fireproofing, these are the people or the people who are working in construction sites, shipbuilding. They are the one who are going to be having high risk of asbestosis. These patients classically are going to be having a trouble that is going to be beginning from the base of their lung. So asbestosis is heavy, right? The best of you will remember the fact your basics are clear. When we are talking about pleural plaque, apart from that, patients are going to be having the development or presence of asbestos body. Asbestos body. Asbestos body, it can be associated with deposition of iron and protein as well. So that is what is going to be given the name of ferruginous body. Ferruginous body. Even that can be asked as a question in the exam. What were you given as an exam question over here was that there was a person who is working in industry. This patient is having coming to you because he's having dry cough. He was also having the presence of a tightness in the chest. And when you were doing the examination of the lungs of this patient in the biopsy, you were having the presence of an appearance which is given the name of shish kebab appearance. Shish kebab appearance. So asbestos particle is going to be having the presence of a shish kebab appearance. That is what you need to remember. So that is another way of asking a question in the exam. Asbestos is an example of a highly carcinogenic substance. Why is it bad? Because it is going to be acting as a mutation causing substance. Second, it is also going to be acting as a promoter. So usually when you are talking about any kind of a cancer causing chemical, या तो म्यूटेशन कराते हैं या फिर वो म्यूटेटेड सेल्स का ग्रोथ कराते हैं. एस्बेस्टोस दोनों काम करता है. इट इज अ इनिशिएटर एज वेल एज अ प्रमोटर. सो दैट इज वन क्वेश्चन. That is what is talked about in PSM as well. When we are talking about asbestos, if a patient is going to be having a exposure of around 20 years, 20 years का अगर exposure होता है asbestos से कारण, the patients are going to be having a development of bronchogenic carcinoma. Bronchogenic carcinoma. Therefore, bronchogenic carcinoma is relatively more common. But after 20 to 30 years of experience, exposure, the patients are going to be having a development of mesothelioma. Right? Now, bronchogenic carcinoma can be seen because of other causes. So it is common, but it is not specific for asbestos. Mesothelioma is an example of a cancer that is going to be more specific for asbestosis. Whenever we are talking about bronchogenic carcinoma, the type of bronchogenic carcinoma that you associate with asbestos is going to be A for asbestos, A for adenocarcinoma. Adenocarcinoma. So if a patient is going to be having asbestos exposure, he can be having adenocarcinoma of the lung also, he can be having mesothelioma also. That is what you are aware of. Now, whenever we're going to be differentiating between them, they are going to be having different types of markers. So we had a discussion about the markers yesterday as well. We can quickly recap. Adenocarcinoma is a number one cancer, A1. So it is going to be having markers which are having either alphabet A or numerical 1. So TTF1, napsin A, surfactant protein A1. They are the markers for adenocarcinoma. ये सब notes में है, आप mentally revise कर रहे हो इसको. Whenever we are talking about the markers for mesothelioma, you are going to be having markers like mesothelin. You are going to be having a marker like WT1. मैंने कल भी बताया था आपको. Wilms tumor 1. You're going to be having a marker that is given the name of calretinine, and you're going to be having a marker called as D240. WT1, D240, calretinine. They are the examples of markers which are going to be associating with mesothelioma. So bronchogenic carcinoma and mesothelioma differentiated on the markers that they are going to be having. Cytokeratin is going to be a marker that is going to be for squamous cell carcinoma, right? So these are the things that we need to remember. Then we are asked a question in the exam, which was with regards to the patient who was having the presence of the this question, which was talking about metabolic disorder. So I will talk about that again in a discussion of hepatobiliary discussion. But the other question asked in the exam, okay, another question which was asked in the exam that I can recall over here is a patient who's going to be having the presence of a condition that is going to be given the name of ARDS. Adult respiratory distress syndrome. Now, when we are talking about adult respiratory distress syndrome, this condition is going to be beginning because of presence of endothelial cell injury. There is also going to be release of cytokines, which is going to be given the name of interleukin 8. What is the role of interleukin 8? This was what was asked to you as a 2024 question. This is responsible for causing neutrophilic activation. Neutrophilic activation. And ultimately, the net result over here is going to be that there is a deposition of fibrin at the level of the alveoli. Right? So, starting event is what is asked of the question. Starting event in ARDS is endothelial cell injury. Remember the role played by interleukin 8. It is responsible for neutrophilic activation. And why is ARDS a bad condition for your patient? Practically is because there is association of deposition of fibrin. So when there is a fibrin deposition, fibrin is going to be responsible for creating a physical barrier. Because of the physical barrier, what you see over as a problem in the patient is going to be that the patients are going to be having no diffusion of the gaseous exchange taking place properly. So that is why you're going to be having ARDS as an example of a condition in which this is not going to be having a very good response with oxygen inhalation. So treatment has to be done for these patients. Now, this kind of a damage can be seen microscopically. This kind of a damage is, as most of you are able to recall that, is going to be given the name of diffuse alveolar damage. Hallmark feature that we are having for ARDS happens to be diffuse alveolar damage. So 5 questions that you need to remember about ARDS. Starting event, role played by interleukin 8, that is neutrophilic activation, the name hyaline membrane disease, the microscopic finding diffuse alveolar damage, and the patients are not going to be having a direct response with simple oxygen supplementation. They would be requiring positive pressure ventilation. That is what you need to remember. Treatment of these patients is going to be the treatment of primary cause. जिस चीज ने endothelial cell injury को start किया था. That can be pneumonia, that can be use of drugs, that can be because of the septicemia, that can be because of infections. Whatever thing was starting over here. COVID-19 का क्वेश्चन यार अब 2025 के अंदर हम एक्सपेक्ट नहीं करते. वो जो डिफ्यूज एल्वेओलर डैमेज था पुराना क्वेश्चन था, बट उसको कोविड-19 के अंदर भी दिया गया था. और उसका रैशनल ये भी था कि फाइब्रिन को आप डिपॉजिट करना कम कर सकते हो बाय गिविंग स्टेरॉइड्स. सो दैट इज व्हाई स्टेरॉइड्स वर इफेक्टिव ओवर हियर, राइट? So these are the things that are asked in the exam. The other important thing regarding ARDS is that it can be associated with development of acute lung injury. और acute lung injury का जो क्वेश्चन आता है जो हमने कल डिस्कस किया था हिमैट के साथ में, that is transfusion related acute lung injury. Which component of blood can be responsible for causing trally most commonly? Which component of blood causes trally most commonly? सबसे कॉमनली कौन सा करता है? सबसे कॉमनली कौन सा करता है? विच कॉम्पोनेंट ऑफ ब्लड? होल ब्लड करता है, आरबीसी करते हैं, प्लेटलेट्स करते हैं, एफएफपी करता है, क्रायोप्रेसिपिटेट करता है. एफएफपी करता है भाई, एफएफपी करता है. तो न्यूट्रोफिलिक इन्फिल्ट्रेशन करा देता है लंग्स के अंदर, एक्टिवेट करा देता है. एफएफपी कॉजेज. व्हाट इज द टाइमलाइन व्हेन ट्रॉली इज बीइंग सीन? फर्स्ट आवर, फर्स्ट 4 आवर्स, फर्स्ट 6 आवर्स, फर्स्ट 8 आवर्स, फर्स्ट 12 आवर्स, फर्स्ट 24 आवर्स. फर्स्ट 6 आवर्स के अंदर करा देता है, राइट? डू वी हैव अ स्पेसिफिक ट्रीटमेंट फॉर ट्रॉली? द आंसर अनफॉर्चुनेटली इज नो, right? So those are the things which we should be having on our tips for the exam purpose. Then we are going to be asked question in the exam, which is on the different types of lung cancers. I think this is all known to you. The example of a lung cancer, which was very common all these years in our country, happened to be squamous cell carcinoma. As of now, this is the number 2 cancer. This is an example of a cancer which is going to be associated with mutation in a gene that is called as P53 gene mutation. So we are going to be having different types of markers that are going to be associated with this P63 and P40. Elder brother and younger sister, that is what say bada bhai choti behan. Then this is going to be an example of a cancer that is going to be causing involvement of central airway. Smokers are going to be having this kind of a cancer. S for squamous, S for smoking. This is what is also going to be having the presence of squamous. So there is presence of hypercalcemia as a paraneoplastic syndrome, also associated with development of cavity formation. The only saving grace in a way in squamous cell carcinoma is that patients are going to be having relatively less aggressive nature of the cancer. In comparison to other cancers like small cell cancer, it is going to be having better prognosis. Because you are having squamous cells over here, so squamous cells are responsible for secretion of keratin. This was a 2 times asked question. So keratin can be seen grossly. It can be in the form of keratin pearls. It can be seen grossly as in, I mean, in case of, I would say the light microscope examination, you can see keratin in case of the electron microscope examination as well. 2 cells which are going to be having the presence of keratin between them. That is what is going to be given the name of keratin bridge. So terms like keratin bridge, keratin pearls, they are what are going to be associated with development of squamous cell carcinoma. So these are the usual standard things that they put up to in the exam regarding squamous cell carcinoma time and again. And of course, this is what is going to be associated with what kind of mutation? P53 mutation. Apart from this, you are going to be having keratin. What type of keratin do we have in squamous cell carcinoma? That is going to be keratin 5 and 6. CK5, 6. So 7 and 20 is for COP, 8, 18 for meloid body, 5 is 6 for squamous cell carcinoma, right? We are revising that for the 4th time. Then we are talking about the example of a lung cancer that is going to be very, very important for the world as well as for our country. That is adenocarcinoma. Classically, it is going to be having a description of a female who happens to be a non-smoker. And this patient is going to be having the presence of an adenocarcinoma. Adenocarcinoma is going to be characterized by, this was a separate image-based question in INICT, November 2023. You are going to be having the presence of these gland-like structures. Gland-like structures. So whenever you're going to be having glandular formation, this is what is going to be associated with adenocarcinoma. Adenocarcinoma, right? What is to be remembered over here is the different types of markers. It's an example of a tumor which is going to be having 3 or 4 important types of markers. TTF, surfactant protein A1, that is what we made a mention of. It is going to be having a marker that is given the name of napsin A, and of course, the patients are going to be having the presence of TTF1. If you're looking at a microscopic level, you're going to be having the presence of tumor, which is going to be having gland formation. Why are the tumors going to be having gland formation? Because different types of genes can be involved over here. One type of gene which can be involved in these patients is going to be epidermal growth factor receptor. Recall the fact, the name of the gene that we talked about, it's a proto-oncogene. It's a proto-oncogene. It's an example of a growth factor receptor, ERB1. The second type of gene that we need to remember over here is going to be a gene that is given the name of ALK gene. ALK gene. ALK gene, right? Why do we need to talk about these different types of genes? Is for the simple fact that there are different drugs which are going to be available for targeting them. We discussed them yesterday as well. These are pharmacology questions, not path. ALK targeting drug is going to be given the name of crizotinib. When we are talking about EGFR drug, that is erlotinib, and this is going to be gefitinib. So erlotinib and gefitinib are EGFR targeting drugs. ALK targeting drug is going to be crizotinib. So nowadays there is a concept what is given the name of personalized medicine. Whatever problem a patient is having, according to that, treat the patient. For your exam, 5 things for adenocarcinoma. It is having the highest prevalence, number 1. Second fact, it is going to be associated with mucin production. When mucin is going to be seen, it can be associated with development of an important paraneoplastic syndrome, clubbing. It can be responsible for causing a development of migratory thrombophlebitis. Question number 3. You are going to be having special markers by which you identify adenocarcinoma. At a microscopic level, you will identify it with the help of gland-forming tumor cells. At the special markers that you need to remember are all going to be remembered as TTF1, surfactant protein A1, and you're going to be having a marker like napsin A. Fifth and the final question that you need to remember with regards to adenocarcinoma of the lung is that this is an example of a cancer which can be associated with certain types of genes for which questions have been asked in the exam, that is ERBB1 as well as ALK gene. When I'm talking about ERBB2, this is going to be associated with the name as HER2/neu, that is associated with breast cancer. When I'm talking about ALK gene, apart from adenocarcinoma of the lung, what is other cancer in which ALK gene is important? Anaplastic lymphoma. Anaplastic lymphoma kinase is seen in case of patients having anaplastic lymphoma. When I'm talking about anaplastic lymphoma, what is the microscopic appearance of the cells? They are going to be having an appearance that is going to be given the name of horseshoe appearance, or they were having an appearance that is going to be given the name of embryoid nucleus. So horseshoe appearance of the nucleus, or as well as embryoid appearance of the nucleus, these cells are going to be given the name of hallmark cells. Hallmark cells. So hallmark cells are the hallmark of anaplastic lymphoma. That is what you need to remember so far as exam questions are concerned. The third important example that we need to remember over here is going to be a patient who is going to be suffering from a cancer that is given the name of small cell cancer, right? Smaller it is in size, but very, very naughty. Jitna chota, utna khota. That's how we remember it. So this is an example of a cancer which is going to be having a property that it is going to be having neuroendocrine origin. Neuroendocrine origin. So that is why it is going to be having the presence of neurosecretory granules, which can be appreciated on electron microscopy. Second fact is because it is having a neuroendocrine origin. So this is an example of a cancer which is going to be secreting lots and lots of hormones. So it is going to be associated with maximum paraneoplastic syndrome. The cancer is going to be having an important property that you are going to be having the presence of tumor cells, which are going to be having a blue appearance because of high mitotic rate. So just read the terms over here. Right. So I said, I'm just going to be highlighting what is important for you to remember, that these are example of small basophilic cells. These are having high rate of mitotic activity, and these cells are going to be highly aggressive in nature. There is no gland formation. Gland formation adenocarcinoma mein hota hai. That is what you need to remember. There is no keratin or squamous pattern because that is feature of squamous cell carcinoma. So that is what you need to remember. Small, highly aggressive tumor cells. Now these tumor cells are going to die quickly if you expose them to radiotherapy or give anti-cancer drugs. But because of their highly aggressive nature, they have a high chance of causing CNS metastasis. So therefore, they are going to be having a poor prognosis. Small cell cancer is going to be having very poor prognosis in spite of having good response to anti-cancer drugs and radiotherapy. Overall prognosis of these patients happens to be really bad. At a microscopic level, you can see tumor cells which are going to be having presence of lots and lots of nuclear material. Tumor cells which are going to be having the presence of lots and lots of nuclear material. So that is why the tumor cells are going to be having a basophilic appearance. They are going to be having the presence of a basophilic appearance. Sometimes the chromatin material from the tumor cells is going to leak out, and that is going to be giving a blue color to the vessels over here. That is what has been given the name of azoparty effect. Has been given in the textbook for quite some time, has never been asked as a question directly. But if you are asked the question, then the bluish staining of the vessel wall is from the tumor cells is going to be associated with the term azoparty effect. Whenever we are going to be talking about the small cell cancer, the small cell cancer is going to be having an important association. This can be associated with a type of MYC that is given the name of LMYC. So what we discussed earlier is that CMYC is what is going to be associated with लेपिडिक पैटर्न का मतलब होता है बटरफ्लाई लाइक पैटर्न मतलब एक फेंस के ऊपर आपने बहुत सारी ऐसे बटरफ्लाइज को बैठे हुए देखा so you are going to be having the presence of a basement membrane or tumor cells are sitting over here. That is lepidic pattern. When we are talking about CMYC, it is associated with Burkitt's lymphoma. When we are talking about NMYC, it is associated with neuroblastoma. When we are talking about LMYC, it is associated with lung cancer. So that is another important thing that we need to keep in mind. Now, because you are going to be having the presence of a neuroendocrine origin over here, so there is going to be secretion of lots and lots of substances over here. So what are the markers that we discussed yesterday in the table as well? Chromogranin, synaptophysin. Chromogranin, synaptophysin, CD56. They are the markers which are seen in case of small cell cancer. Second thing is, we discuss about an example of a neuroendocrine tumor which was having the presence of one special marker. Yes, that is what you need to remember. INSM that was having a nuclear staining. Rest of the markers are not having nuclear staining. They are having a membranous staining or cytoplasmic staining, right? Whenever we are talking about this kind of a tumor, it can be associated with secretion of lot of hormone-like substances. So there is a high risk for development of paraneoplastic syndromes. That is what is mentioned in your notes as well. SIADH. And the patients are going to be having a development of a condition that is given the name of Cushing syndrome, or the patients can be having the presence of calcium imbalance as well, right? One of the important paraneoplastic syndromes or the important finding in a patient having small cell cancer is formation of antibodies against calcium channels. When there is formation of antibodies against the calcium channels, patients can have muscle weakness, and that kind of a muscle weakness is what is going to be given the name of Lambert-Eaton syndrome. This is what is going to be given the name of Lambert-Eaton syndrome. So Lambert-Eaton syndrome is something that you would associate in a patient suffering from small cell cancer. Clinically, why this cancer is important is because when you have a patient having lung cancer, you divide whether the patient is having small cell cancer or non-small cell cancer. Non-small cell cancer usually has better prognosis. Small cell cancer has got a poor prognosis. So accordingly, you will tell your patients. And that is what is likely to be asked in exam as a question. So this is what you need to remember. Then we are going to be having a cancer that is going to be given the name of large cell cancer. It is a diagnosis of exclusion. No keratin, no glands, no azoparty effect, no neuroendocrine granules over here, no presence of hyperchromatic cells or having a small cells with nuclei. This is going to be having an important finding that patients are going to be having this cancer. This is seen in case of non-smokers. And the patients are going to be having the presence of secretion of estrogen-like substance, because of which they can be having a development of a gynecomastia-like manifestation. These are the four classical examples of bronchogenic carcinoma. Which of these cancers is going to be associated with most strongly with asbestos? The answer is adenocarcinoma. Which of these four is going to be having the strongest association with smoking? The answer that you need to remember is small cell cancer. Don't make a mistake on that one. The fifth example of a tumor that we need to have an idea is going to be mesothelioma. Whenever we are going to be talking about mesothelioma, I just made a mention of the fact. This is how we are going to be distinguishing. Mesothelioma is itself telling you what a lot of you were able to recall as well. So specific. So very specifically associated with asbestos. Markers that we are going to be having over here are going to be calretinine, WT1, D240. And whenever we are going to be talking about adenocarcinoma, it is going to be having markers like TTF1, SPA1, surfactant protein A1. It is going to be having a marker that is going to be given the name of napsin A. Second thing that you need to remember over here is that we can be distinguishing them on the basis of electron microscopic appearance. This was an INA question, so we just need to remember over here. Smokers में सबसे कॉमन जो होता है डॉक्टर साहब डॉक्टर आस्था दैट इज कॉमन सेल स्ट्रांगली एसोसिएटेड होता है स्मॉल सेल याद रखना. So whenever we are going to be talking about mesothelioma, I just want you to write M over here. So it is going to be M, long branching villi. Long branching villi, that is what you need to remember. Whenever I'm going to be talking about adenocarcinoma is like this. Non-branching, short villi. Short non-branching villi is what is need to remember in context of a patient who is going to be having adenocarcinoma. So in a line, write alphabet A, write alphabet M. You'll always remember it, not difficult at all. So A alphabet is non-branching, short in size, whereas whenever we are talking about M alphabet, that is going to be longer in size and that is going to be having a branching over here. So branching microvilli is going to be seen as a feature of mesothelioma. That is what you need to remember. So that will take care of a INI question as well, which was asked in the exam. Then what we need to remember over here is going to be the presence of the lesion, which is going to be given the name of a pulmonary hematoma. Now, pulmonary hematoma is going to be an easy question for the exam for the simple reason that these are the patients who are going to be having the presence of, on the X-ray as well as on the CT, they're going to be having the presence of a popcorn lesion. There is a presence of a popcorn lesion. So popcorn calcification is what you see in a patient who's going to be having pulmonary hematoma. That's the easy thing that is asked in the exam. Popcorn calcification, the breast tissue is going to be a finding of course, you know the answer. Popcorn calcification, the breast tissue is going to be a finding of fibroadenoma, which is the commonest tumor that is seen in the breast tissue of a young female breast mouse. And if I'm talking about the popcorn cells, we associated them in context of something like popcorn cells is what we associated with something like the non-classical Hodgkin's lymphoma. Non-classical Hodgkin's lymphoma. What was the marker for non-classical Hodgkin's lymphoma? Marker for non-classical Hodgkin lymphoma, that was CD20, 15 and 30 were negative. So total 4 or 5 questions which had been asked in the exam. If I talk about the recent exams, the question on ARDS was asked in the exam. Last exam is a question last year. Then we got a question in the exam on the different types of markers, the special markers that we are having for adenocarcinoma as well as small cell cancer. Then we got a question in the exam on asbestosis, which was asking you about the shish kebab appearance, as well as a question which was asking you about the presence of the tumors caused because of asbestos. Then we got a question in the exam which was on anthracosis associated with the black exogenous pigment. And then we got a question in the exam on emphysema, which was talking about the presence of micronodular cirrhosis as well as the development of emphysema. So this is what you need to remember. And subsequently, we got a question in the exam which was asking about the defect that is going to be seen in the patients who are going to be having the presence of a popcorn calcification, that is pulmonary hematoma. So I mean, those are the usual things which have been taken care of the exam. So not very difficult questions, but I reiterate the fact that apart from tuberculosis, I mean tuberculosis तो bread and butter है examiners का, क्योंकि फार्मा का क्वेश्चन बनता है, माइक्रो का क्वेश्चन बनता है, पीएसएम बनती है उससे. So apart from tuberculosis, you need to be familiar with the lung tumors, all 5 subtypes, especially squamous cell, small cell adenocarcinoma, and mesothelioma to be read in specific. Hematoma is benign. Hematoma is benign over here. तो hematoma important होता है. Hematomatous polyps are the hot favorite for the GI tract system. So juvenile polyp, Peutz-Jeghers polyp. And when we are talking about hematoma in the lungs, so pulmonary hematoma, which is having the popcorn calcification, right? So that is what you need to remember over here. हाँ जी, एम्फाइसीमा के अंदर अल्फा 1 एंटीट्रिप्सिन के अंदर आपको देखने को मिलती है. हाँ जी, मेलोरिडेंक. ठीक है. So these are the things that we just need to recall over here. Now having a discussion about दिल की बातें कर लेते हैं. So that is going to be cardiovascular system. Now नहीं मुस्कान, वो लगेगा आपको ऐसा, आपको ना चीजें बहुत सारी सुनी हुई हैं. It is just that a lot of this information sometimes is not being recalled by us. उसी टाइम पे ना रिकॉल नहीं हो रही. बट आप इसको आराम से सुनोगे अगर, आई मीन लेट्स से फॉर एग्जांपल यू फिनिश ऑफ द क्लास एट 11 एंड यूर इन अ लेजर मूड, तो आप आंख बंद करके सुनोगे ना, आपको लगेगा बहुत सारी चीजें आपने सुन रखी है, राइट? सो इट्स अ क्विक recap. Of course, that is the purpose of having a lab, no? Then we are talking about the cardiovascular system. Cardiovascular system is what is going to be associated with the classical conditions. Ischemic heart disease, all-time favorite. Then rheumatic heart disease, ectopic questions. Cardiomyopathy is what is making a cardiomyopathy is actually what is going to be the topic which has made a comeback after quite some time, right? But this is what we just need to have an idea. So ischemic heart disease, myocardial infarction, we understand the fact that the patient is going to be having the presence of a chest pain. Unfortunately, nowadays we do not have any specific age in which we can say the patient is going to be having heart attack because of the presence of multiple reasons. A lot of people are going to be having the presence of heart attack, unfortunately, even at a younger age, right? Lots and lots of reasons. Some say vaccines, some say microplastics. Ultimately, it is lack of exercise and a bad food and highly stressful lifestyle that we have. So when we are talking about myocardial infarction, what you need to remember over here is going to be the patient is going to be having the presence of a chest pain, nausea, vomiting, excessive sweating, which is called as diaphoresis. What we are going to be having over here is a patient who is going to be having the presence of increase in the enzymes. The early enzymes which are going to be useful for making a diagnosis of myocardial infarction are heart fatty acid binding protein and IMA, ischemia modified albumin. These are the early markers. The classical marker, which is going to be called as a gold standard marker for making a diagnosis of myocardial infarction, are cardiac troponins. They are cardiac troponin T and cardiac troponin I. Example of an enzyme which is asked in the exam because of its special property, which is called as LDH. So normally in our blood, we are having LDH2 more than LDH1. 2 is always more than 1, simple maths. But in a patient who's going to be having heart attack, 1 becomes more than 2. LDH1 becomes more than LDH2, so that is called as flipping of the LDH ratio. Another reason why we talk about LDH is because this is helpful in making a diagnosis of heart attack or the affected infarcted area with the help of a staining as well, that is given the name of TTC. At a microscopic level, one of the earliest findings that we have in case of heart attack is waviness of the fibers. This is because of presence of intracellular edema. So the fibers are going to be having the presence of an irregular appearance. So that is what is going to be observed over here. This wavy fiber appearance is going to be seen within the first few hours. So this is going to be observed within 4 to 24 hours. That is what you need to remember. Then within the first day, you're also going to be having the presence of neutrophilic infiltration. Neutrophilic infiltration is obviously less in number in the first 24 hours. It is going to be becoming more on the second and third day. So this component is what is given the name of early neutrophilic infiltration. That is between the 24 hours. This one on the second and third day is going to become very large. So that is given the name of massive neutrophilic infiltration. So we got a question in the exam, which was factually not a correct question, but I want you to remember earliest change after 4 to 6 hours is edema of the fibers. Early neutrophilic infiltration, what is going to be seen in the first 24 hours, and second and third day, you are going to be having massive neutrophilic infiltration. After 3 days, neutrophils are going to disappear and you are going to be having the presence of macrophages. So these three important images are absolutely must know. Then what we are going to be having after 3 days is going to be the deposition or replacement of neutrophils by the macrophages. And what we are going to be having over here is the deposition of the granulation tissue. Now, this is a time when you are going to be having the appearance of the macrophages in the granulation tissue. And unfortunately, this is also the time when the cardiac tissue is going to be the weakest. So there is a high risk of development of what we read in medicine by the name of cardiac rupture syndrome. Cardiac rupture syndrome can be associated with the damage at the level of the mitral valve. So there is a damage at the level of the papillary muscle. There can be a damage at the level of the interventricular septum, or there can be a damage at the level of the anterior wall. I want you to remember the term cardiac rupture syndrome is having the maximum chance between 3 to 7 days after a heart attack. After a heart attack, that is what you need to remember, right? ये पीवाई क्यों आपका इसलिए गलत हुआ था डॉक्टर दर्शन, क्योंकि उसमें ना वैल्यू अलग दे रखी थी। उसमें मेरे दोस्त वैल्यू क्या दे रखी थी, उसने क्वेश्चन के अंदर बोल रखा था फर्स्ट 2 to 3 आवर्स। सो फर्स्ट 2 to 3 आवर्स में तो न्यूट्रोफिल्स नहीं आते, लेकिन ब्रिस्क न्यूट्रोफिलिक इन्फिल्ट्रेशन जो आपको देखने को मिलती है वो आपको देखने को मिलती है सेकंड एंड थर्ड डे, राइट? तो वो क्वेश्चन ही ऐसा फ्रेम था, उसमें जो बेस्ट ऑप्शन आपको ध्यान रखनी है, अगर हम फ्यूचर में एज्यूम करेंगे कि एग्जामिनर्स मतलब ऐसा टाइपो एरर ना करें, तो आपको ये वाले टाइमलाइंस याद रखें। Then we are going to be talking about, apart from cardiac rupture syndrome, what we need to remember over here is the concept of the staining. The staining is going to be done with the help of triphenyl tetrazolium chloride. Triphenyl tetrazolium chloride is going to be reacting with LDH1. So whenever we are going to be talking about the presence of the type of LDH which is present in the cardiac tissue, that is LDH1. So if I'm going to be having a patient who has died and I perform an autopsy and I put a stain, the normal tissues are going to be having a red color. So that is what we said, and I've said it so many times. हाँ जी, बिल्कुल ठीक कह रहे हो अनुकृति, जियो मेरे लाल। सो आई होप दैट जैसा ब्रह्मजोत ने किया वैसे आप लोग भी कर लो, रैंक 98 जिन्होंने ये दिया था निमोनिक। सो व्हेन यू गिव अ ब्लेसिंग यू से दैट जियो मेरे लाल। सो रेड कलर इज गोइंग टू बी सजेस्टिव ऑफ लिविंग स्टेट, राइट? द वन विच इज गोइंग टू बी डेड, दैट इज गोइंग टू बी पेल, ठीक है? जो मर गया वो पेल गया। सो पेल इज गोइंग टू बी द डेड वन। सो दिस व्हाइटिश कलर और द व्हाइट येलो कलर इज डेड एरिया, दैट इज व्हाट इज गोइंग टू बी शोइंग विद द लीकेज ऑफ द एंजाइम, right? So red color is suggestive of live tissue. The pale color is suggestive of the dead tissue. That is what you need to remember. So 5 questions regarding the enzymes. Best enzyme for making a diagnosis of heart attack is cardiac troponin. The earliest enzyme for making a diagnosis of heart attack is heart fatty acid binding protein. Ischemia modified albumin also is an early marker. The enzyme which is going to be increasing after a long time or a long gap is LDH. The flipping of ratio is going to be seen with LDH, wherein LDH1 becomes more than LDH2. And the LDH enzyme, which is going to be useful for the purpose of staining and diagnosis of myocardial infarction, is the stain is used as triphenyl tetrazolium chloride, right? We then have a concept of reperfusion injury, which is going to be an example of, this is a keyword to be remembered, free radical injury. So whenever we're going to be old infarct नहीं है यार, old infarct तो ऐसा आपको मतलब ये वाला जो infarct है ये pale area, अगर आपको ये करो, अच्छा ये वाला कह रहे हो, हाँ this one is old, ये पुराना infarct हो सकता है which is going to be because of deposition or replacement of the cardiac tissue by the collagenous tissue. When we are talking about reperfusion injury, it is an example of a free radical injury. पहली चीज याद रखनी है, reperfusion injury something which is thankfully rare but it is seen, and what it is going to be talking about is patient was having heart attack, he has been given a fibrinolytic drug, thrombolytic drug has been given to the patient, and this thrombolytic drug is responsible for causing damage at the level of the cardiac fibers. As a result of which, what you find over here is you're going to be having in between the pink color bands. The pink color bands are going to be seen. So these pink color bands are going to be given the name of contraction bands. So this is what is going to be given the name of contraction band necrosis. Contraction band necrosis. So contraction band necrosis is what is telling you that there is a presence of a reperfusion injury. What are the other examples of reperfusion injury that are commonly asked in your exam? Reperfusion injury, free radical injury can also be seen in case of a patient who is going to be having the presence of something like, let us say, the conditions in which there is a copper overload or there is an iron overload. These are commonly asked questions in exam 2024 में तो 23 और 24 में 3 questions आए इसके ऊपर. So whenever we are talking about hemochromatosis or whenever we are going to be talking about Wilson's disease, the patients are going to be having free radical injury, which is going to be seen because of this. One question which was asked as a radiology question was the free radical injury is also going to be seen in patients who are going to be having a history of radiation injury. Radiation injury, right? So radiation injury is again what is going to be associated with the development of reperfusion injury. Coagulative necrosis क्यों हो रहा है? Okay, coagulative necrosis इसलिए हो रहा है डॉक्टर साहब because you are going to be having the deprivation of the blood supply to the affected cardiac fibers. So whenever there is an ischemia, there is going to be hypoxia. Whenever there is hypoxia, there is going to be development of the commonest pattern of necrosis, that is coagulative necrosis. Coagulative necrosis. Why thrombolytics are responsible for causing free radical and reperfusion injury? You have a clot. You have a clot over here. You give a drug and this clot is going to vanish. When the clot is going to vanish, lot of blood is going to be coming. When a lot of blood comes, blood is going to be having white blood cells. White blood cells produce free radicals. Free radicals cause more damage to the heart. That's why there is a trouble. That's why there is going to be a trouble, right? So what you can understand over here is if I just say an example of a strong gush of blood. Blood बहुत तेजी से आ रहा है. कहीं पे obstruction है, कहीं पे. So there is going to be no blood coming or less blood is coming. Suddenly you remove the obstruction, lot of blood is coming with a gush. So extra amount of blood coming with a gush also is bad. That is what is going to be causing the trouble, right? So this is what you need to remember so far as reperfusion injury is concerned. Then we are asked question in exam on rheumatic heart disease. I think we can just talk about it over here very quickly. The characteristic feature that we are going to be having in case of rheumatic heart disease is going to be the presence of Ash's body. Where do we have the Ash's body present? Endocardium, myocardium, pericardium. Can you just let me know the answer? The answer is all. The answer is all. Where do you see it? Maximally, it is going to be seen in the myocardium. Maximally seen in the myocardium. Can be seen in all, but is going to be seen in myocardium. Rheumatic heart disease, of course, is a type 2 hypersensitivity reaction. The children typically are going to be having a history of a streptococcal sore throat. So there is going to be a presence of anti-streptococcal antibodies. The anti-streptococcal antibodies are going to cross-react with the joints. That's why these patients are going to be having migratory polyarthritis. That is the commonest clinical manifestation, migratory polyarthritis. When we are talking about a patient who is going to be having the rheumatic fever, he is also going to be having the presence of pancarditis. The reason for migratory polyarthritis and pancarditis is a concept that we talked about earlier that is given the name of molecular mimicry. Molecular mimicry. Antibodies are produced against bacteria, but antibodies start attacking the heart and the joint also. Molecular mimicry. What we are also going to be having in these patients is going to be the concept of cross antigenicity. Cross antigenicity. Right? Rheumatic heart disease patients are going to be diagnosed with the help of a criteria that is given the name of modified Jones criteria. So these patients are going to be having migratory polyarthritis. They are going to be having the presence of pancarditis. They are going to be having nodules. What is the name given to nodules? Subcutaneous nodules. They are going to be having the presence of erythema marginatum. And these patients can be having involuntary purposeless movement. Involuntary purposeless movements को हम नाम देते हैं साइडेनम स्कोरिया. साइडेनम स्कोरिया को पेडियाट्रिक्स के अंदर आप पढ़ते हो. It is also called as milkmaid's grip. Milkmaid's grip. So milkmaid's grip is what is associated with Sydenham scoria. Keyword है, याद रखना है आपने. So baby who's going to be having streptococcal pharyngitis and afterwards having these manifestations are going to be having this condition. Sydenham scoria is not to be confused with the Huntington scoria. That is what we are going to be having, in which we are going to be having the presence of caudate nucleus involvement, right? Caudate nucleus involvement. The other thing regarding rheumatic heart disease is that yes, हाँ वो autosomal dominant CAG वो आपको याद आ गया. When we are talking about patients who are going to be having rheumatic heart disease, another thing that we need to remember in these patients is the commonest valve that is affected. It is typically going to be a mitral valve, right? Then it is going to be aortic valve, then it is going to be tricuspid valve, and then it is going to be pulmonary valve. ठीक है, तो आप इसको पढ़ना भी मत, आपको वैसे याद हो जाएगा. मत पढ़ो, ये तो आपको वैसे ही याद है. Mitral is the most common, and pulmonary is the one which is going to be the last. Pulmonary is the one which is going to be in the last. So different types of questions which have been asked in the exam. In the initial stages, patients are going to be having the presence of mitral regurgitation. That is why the patients are going to be having the presence of what is going to be given the name of the thickening of the left atrial wall. That is what is given the name of McCallum plaque. McCallum plaque. And later on, the patients are going to be having fibrosis and deposition of calcium over here, which is going to be responsible for causing mitral stenosis. So this was NEET PG 2019's question. Why is a patient having rheumatic heart disease having stenosis? Because of deposition of fibrous tissue, because of deposition of calcium over here as well. And that is what is going to be associated with the term fish mouth stenosis. Fish mouth stenosis, right? So those are the basic things regarding rheumatic fever. Of course, nowadays we are going to be having the presence of the modified WHO criteria for making a diagnosis of rheumatic fever, depending upon whether it is in the endemic area or in the non-endemic area, right? So low risk area and the high risk areas, that is what we talk about, but that is going to be domain so far as medicine is concerned. Next thing that we need to remember over here is going to be the vegetations. I just need to quickly recap over here. All these vegetations are important. In case of rheumatic heart disease, the vegetations having a characteristic location, line of closure, and they are extremely tightly attached. There is no embolization. McCallum plaque hota hai, doctor sahab, when there is mitral regurgitation, there is thickening of the left atrial wall. Thickening of the left atrial wall, that is called as McCallum plaque, right? So rheumatic heart disease vegetations are small in size. They are tightly attached, so they cannot detach, and therefore there is no embolization. Where are they located? They are located along the line of closure. So the valve is having a line during which it is going to be having the closure, and that is where the vegetations are going to be seen. In contrast, if I'm going to be talking about merantic endocarditis, this was the basis of a question asked in 2023. Merantic endocarditis is going to be also called as non-bacterial thrombotic endocarditis. Non-bacterial. That means no bacteria is involved over here as well. When bacteria is not involved over here, then this is also going to be small and sterile. This is also going to be present along line of closure, but it is having the presence of a hypercoagulable state. That means more chances of clot formation. So that is why it is associated with embolization. This is exactly what was the question given to you in the exam. It is seen in patients suffering from acute promyelocytic leukemia. It is also seen in a patient suffering from pancreatic cancer. Promyelocytic leukemia as well as pancreatic cancer. So non-bacterial thrombotic endocarditis is what you need to remember is having these important properties. Whenever we are going to be talking about patients who are going to be having infective endocarditis, 2023's question, NEET exam, infective endocarditis is diagnosed with the help of Duke's criteria. There is bacteria over here. So fibrin, platelets, and bacteria. So definitely the vegetations are going to become bulky. They are having bacteria, so they cannot be sterile. Bacteria will secrete enzymes that will cause breakdown of the vegetation. So they are going to be having embolization, right? So these are going to be associated with very high degree of embolization. Very high degree of embolization, right? That's what you need to remember. The other thing that you need to remember is Libman-Sack endocarditis. Libman-Sack endocarditis is seen in a patient suffering from SLE. In patients suffering from SLE, what you are going to be having is vegetations are going to be present on the valve surface. Both surface of the valves are affected. Lower surface is affected more in comparison to upper surface. Lower surface is affected more in comparison to the upper surface, but both surfaces are affected. However, the good point is that it is going to be having less chances of embolization. So they are small, but they are going to be having involvement on the lower surface in comparison to the upper surface. So first important hint in the exam question is size. Second is location. Once you look at the size, the question says it is bulky and it is present on upper valvular surface. The answer is infective endocarditis. The question says the size is small or moderate and it is located on the both the surface of the valve. The answer is Libman-Sack endocarditis. When the question says size is small and present on line of closure, then what you have to remember is a hint. If it is a patient of cancer or it is a patient who's going to be having embolization, then this is merantic. आसान है याद करना, कैंसर के अंदर मेटास्टेसिस होगा तो कैंसर का जैसे कैंसर सेल स्प्रेड करता है ऐसे ही वेजिटेशन भी स्प्रेड कर जाएगी, दैट इज एम्बोलाइजेशन. सो विद कैंसर्स there is a spread, with the vegetation over here there is a spread, right? And when we are talking about rheumatic heart disease, it is going to be associated with no chances of embolization because it is very tightly attached. And where exactly is it located? Small and sterile, and it is going to be located along the line of closure. So these are the things that we just need to remember over, right? When we are talking about the cardiomyopathies, now cardiomyopathies are going to be hot favorite area for your exams, and that is what you need to definitely remember with regards to the questions that they are being asking you these days. Now different types of cardiomyopathies are going to be having different trouble. That's the first one that we are going to be talking about. The first one that we talk about over here is going to be HOCM. HOCM को आप ऐसे लिख सकते हो, उल्टा लिख दोगे तो MCH बन जाएगा. Or what you can remember over here is the patients are going to be having a trouble. The trouble in these patients is going to be seen in the myosin chain. Heavy chain, HOCM, heavy chain of myosin, is what is going to be affected in the patients. Heavy chain of myosin is what is going to be affected in the patients. As a result of which the patients are going to be having a dynamic obstruction. There is a peculiar shape that you're going to be having so far as the ventricle of the patient is concerned, that is given the name of a banana-like heart. There is a dynamic obstruction of the left ventricle because the patients are going to be having asymmetrical ventricular-septal hypertrophy. Asymmetrical ventricular-septal hypertrophy, right? So, banana-like heart, there is an asymmetrical ventricular-septal hypertrophy. The problem of, or the meaning of the word dynamic obstruction is, more is the heart rate, more is the obstruction. And if there is going to be more obstruction, what will happen to the cardiac output? The cardiac output is going to be going down. Now, what is going to be the trouble? So that means when the person is going to be doing exercise, there is more obstruction. If there is more obstruction, then this is what is going to be responsible for problem number one, cardiac output goes down. And second, there is too much of heart load on the heart, strain on the heart. When there's too much of strain on the heart is going to be going into a state of arrhythmia. So this is what is going to be responsible for causing death of the patient. Remember this fact. It is the arrhythmia that you're going to be having, which is going to cause mortality or death of the patient. Arrhythmia causes death of the patient. So when heart is under strain, it is going to be going into a fib. It's going to be going into a ventricular arrhythmia, and that is what is going to cause death of the patient. So easy questions that you need to ask in the exam is, let us say we are talking about an athlete who's going to be playing. We're talking about a footballer who is in the ground. We are going to be talking about an individual who's going to be having a heart rate increasing his complications or worsening his symptoms. That is what is going to be associated with the patient who's going to be having a HOCM. What is going to be asked in the exam as a question for HOCM? A young athlete collapses on the field and dies. On autopsy, he is going to be having a heart which is going to be having the presence of a banana-like ventricular cavity. Or the question is going to be talking about the fact the patient is going to be having asymmetrical ventricular septal hypertrophy. And what is going to be the cause of death of this patient? The cause of death of this patient is going to be the presence of arrhythmia. Now, when you do an autopsy of this patient, I mean, that's a norm in the US as well. So when you're going to be doing an autopsy of this patient, the cardiac fibers, instead of having a proper arrangement, they are going to be having a haphazard arrangement. Haphazard arrangement. Cardiac fibers are going to be in a haphazard fashion. So this is what is going to be given the name of helter-skelter arrangement. Helter-skelter मतलब इधर उधर तबाही से हो रखी है. Helter-skelter मतलब they are not in a discipline. Discipline में नहीं है, so that is called as disarray. So myocyte disarray or helter-skelter arrangement is a term. Myocyte disarray or helter-skelter arrangement is a term that you see in a patient who's going to be suffering from HOCM. Genes याद कर सकते हो ना तो बहुत अच्छी बात है. Otherwise, इतना basic सी चीज याद रखना that the patients are going to be having the presence of the beta myosin heavy chain defect over here, because of which there is a helter-skelter arrangement. There is asymmetrical ventricular septal hypertrophy. There is going to be strain on the heart, especially at the time when the heart rate is going to increase, and arrhythmia is what is going to be causing death of this patient, right? So how do you take care of this patient? Either what you can do for this patient is going to be radio frequency ablation, right? It's an example of typically an autosomal dominant condition. Genetic condition है ना, तो autosomal dominant होती है. The other thing that you have to do for these patients is you have to control their heart rate. Heart rate can be controlled with the help of drugs, which are going to be drugs like beta blockers. Right? The second important drug that you need to remember, ideally would be you carry out a heart transplant, cardiac transplant. Cardiac transplant का cost पता है किसी को? In general, I mean, beyond the fact. On an average, cardiac transplant is having a cost of 1.2 crores, right? Everybody in the country can't afford, right? So we have to symptomatically manage the patient, and symptomatic management can be done with the help of drugs like beta blockers, right? The other drug which can be given for these patients is what we are talking about or making a mention of over here, that is mavacamten. Mavacamten, yes. If you are aware about this, I'm more than happy, but this is what you just need to have an idea. Mavacamten is an example of a drug that is given for a patient who's going to be having the presence of who's going to be having HOCM. ठीक है? That's what you need to remember. नहीं, मोटा भाई और छोटा भाई का पॉइंट नहीं है यार, बहुत ज्यादा पैसे होते हैं. आई मीन यू हैव टू थिंक लॉजिकली ना. उसके बाद ट्रांसप्लांट के बाद कौन सा जिंदगी बहुत अच्छी हो जाएगी. उसके बाद इम्यूनोसप्रेसिव थेरेपी है, उसके बाद डेवलपमेंट ऑफ सेकेंडरी इन्फेक्शन का खतरा रहेगा, एंड देन द पेशेंट हैज टू बी मेंटेन्ड. सो यू ट्रीट अ इंडिविजुअल, यू डोंट ट्रीट अ डिजीज, राइट. डॉक्टर को उसमें से कितने मिलते हैं? 5 लाख रुपए. इसका अगर डिस्कशन कोई फायदा नहीं हो यार, पहले बन जाओ फिर कमा लेना. Then what we are going to be talking about over here is going to be dilated cardiomyopathy. Dilated cardiomyopathy is going to be an example of a condition in which you are going to be having the dilatation of all the 4 chambers of the heart. So there is going to be dilatation of both the atria, as well as there is going to be the development or dilatation of all the ventricles, right? That is what you need to remember. Whatever we are going to be having in these patients, what we can observe in these patients is that this can be having a genetic cause as well as a non-genetic cause, right? The non-genetic cause of development of this kind of a condition is, number one cause is what is going to be seen in youngster also these days is alcohol. So in the short time when the patients are going to be consuming too much of alcohol, that is what is going to be given the name of binge drinking. So that is what is going to be causing a trouble. The other reasons for having development of this condition is pregnancy. A third reason, which can be exacerbating pregnancy problem, is going to be anemia. Severe anemia is responsible for causing development of hyperdynamic circulation that can be causing a trouble. Anemia along with pregnancy. Pregnancy is a fluid overload condition that can be causing a problem. Patients can be having a exposure of drugs like alcohol, even that can be causing a problem. Or the patients could be having conditions in which they are going to be having the presence of exposure to certain types of drugs. तो कार्डियोटॉक्सिक ड्रग्स हमें पता ही है फार्माकोलॉजी के अंदर, जैसे डॉक्सोरुबिन हो गई, डोनोरोबिसिन हो गई, हर्सेप्टिन हो गई, ट्रास्टोजुमैब हो गई, right? Pertuzumab ho gayi. These are example of drugs which are responsible for causing the trouble, right? So these are the examples of drugs which are responsible for causing dilated cardiomyopathy. In the genetic causes, what you need to remember over here is patients can be having a problem in a gene that is given the name of TTN gene. TTN gene is going to be coding for a protein that is given the name of titin, and that is what is going to be responsible for causing the trouble. So when the heart is going to be dilated, it cannot contract properly. When it cannot contract properly, that is what is going to be responsible for causing सिस्टोलिक डिस्फंक्शन. सिस्टोलिक डिस्फंक्शन हेमोक्रोमेटोसिस में दोनों हो सकते हैं. आयरन ओवरलोड can be responsible for causing dilated as well as restrictive cardiomyopathy, right? So these are the facts that we need to remember. So if I'm talking about beta MHC, it is seen in case of HOCM. If I'm talking about TTN gene or titin, it is involved in a patient having dilated cardiomyopathy. Now, dilated cardiomyopathy is going to be having a non-specific finding that the patients are going to be having the presence of hypertrophy of the cardiac fibers. Hypertrophy of the cardiac fibers. I must tell you, hypertrophy of the cardiac fibers can be seen in other conditions also. But one point which can be helpful for you to crack the question in the exam is, if a patient is going to be having TTN gene mutation, then they are going to be having the nucleus which is going to be given the name of ninja star appearance. Ninja star appearance. So the question makes a mention of ninja star appearance plus myocyte hypertrophy. Then of course the answer is going to be dilated cardiomyopathy. Right? Now this is what is going to be Hanji. So when we're going to be talking about dilated cardiomyopathy, again, the definitive treatment is going to be cardiac transplant. There is nothing that you can do much for these patients, but that's what you just need to remember. Symptomatic management for heart failure has to be done. This was an example of a question that was asked in the exam, I believe. Okay. So this is what is going to be associated with, in case of hypertension, what you observe in the patients is going to be that there is going to be an increase in the size of the nucleus. That's what is going to be given the name of boxcar nuclei. Myocyte dysuria is going to be a feature of HOCM. Hypertrophy of the cardiac fibers is a feature of dilated cardiomyopathy. And whenever I'm going to be talking about myocyte vacuolation, that is going to be a feature of subacute ischemia. Subacute ischemia, right? So these are the important things that we need to remember. Of course, what I have not made a mention of over here is restrictive cardiomyopathy. Restrictive cardiomyopathy is going to be seen most commonly in a patient having a amyloidosis. And the classical manifestation of this would be a patient is going to be having a pale pink appearance of amyloid, which is deposited extracellularly. Pale pink appearance of amyloid that is deposited extracellularly. How will I confirm that this is amyloid only? By doing a staining with congruent. The next one that all of you are having an idea is what is going to be given the name of broken heart syndrome. Takotsubo cardiomyopathy. So in case of intense emotional stress, that is what is going to be given the name of broken heart syndrome. That is what is going to be associated with Takotsubo cardiomyopathy, more as an example of a clinical question and more in the examples of the cardiac findings and the echo findings that are going to be having in these patients. But just remember the fact that this is broken heart syndrome. Holiday heart syndrome was, please remember the fact, dilated cardiomyopathy. Broken heart syndrome is Takotsubo cardiomyopathy. We have a condition in which the patients are going to be young patients who are unfortunately going to die. That's a condition that is going to be given the name of ARVC, arrhythmogenic right ventricular cardiomyopathy. Cardiac fiber is being replaced by fat or fibrous tissue. Arrhythmogenic right ventricular cardiomyopathy. So what you need to remember over here is that in the right ventricle, the cardiac fiber has been replaced by fatty tissue or the fibrotic tissue. That is what is going to be given the name of ARVC, arrhythmogenic right ventricular cardiomyopathy. So importantly, 5 types of cardiomyopathies about which we need to have an idea: dilated, hypertrophic, restrictive, Takotsubo, and ARVC. That is what you need to remember. Yes, you are going to be having a problem with the young athlete over here as well. Even this patient is going to be having a sudden cause of death. But it just depends upon what is the question that is mentioned. So on autopsy, if you're having a banana-like heart, and if you're going to be having the presence of asymmetrical left ventricular hypertrophy, then you're going to be talking about something like the HOCM. If the question talks about the patient in which the biopsy showed you that there was more deposition of fat, there was more deposition of fibrous tissue, which replaced the cardiac fibers, then we are thinking in terms of something like ARVC. right? So that is what you just need to. When we are going to be talking about sarcoidosis, can there RCM? When we are going to be talking about myocarditis is going to be an example of a condition. Myocarditis is going to be an example of a condition in which the patients are going to be having the presence of inflammation. The commonest reason for development of myocarditis is a viral infection, and the virus causing this condition is parvovirus. Second virus that you need to remember in the exam is going to be Coxsackie B virus. And you need to remember the example of a parasitic infestation that is responsible for causing myocarditis, which is going to be given the name of trichinella. Whenever you're going to be having an inflammation caused by a virus, which cells are going to infiltrate? Lymphocytes. So this is an example of a condition in which you're going to be having the presence of lymphocytic infiltration. Exactly the similar question what was asked in the exam, that is why we are not going into too much of details. So patient having a history of viral infection, patient is having a history of lymphocytic infiltration. There is a necrosis at the level of the myocardium. That is what is going to be causing myocarditis, right? Don't forget the fact when you're talking about parvovirus, we had a discussion yesterday. It is going to be having an appearance which is given the name of slat cheek appearance. It is responsible for causing aplastic crisis in case of patients having hemolytic anemia. It is responsible for causing only a transient damage at the level of the RBCs, but it can cause a persistent damage in immunocompromised individuals. And this is the one which is going to be associated with the development of myocarditis as well. Taking care of a question which is going to be talking about the cardiac tumors. Of course, anybody asking a question on the commonest cardiac tumor, answer has to be secondaries or metastasis. Which type of cancer is going to be causing secondaries to the heart? The answer is going to be straight away lung cancer. Lung cancer, no doubt about that. Then we are asked a question in the exam. This was asked in 2023 and 2024, atrial myxoma. Myxoma is an example of the most common primary cardiac tumor that is seen in case of adults. A for adults, A for myxoma. A for remember atria as well. So myxoma is going to be arising in predominantly the left atrium. It's going to be arising in the left atrium. And please remember the fact that this is going to be having a specific site where it is going to be associated with the term fossa ovalis. These patients are going to be having the presence of a tumor in which the patients are going to be having a tumor which is going to be hitting the wall of the left atrium on atrial contraction. So this is what is going to be associated with the term tumor plop. Tumor plop. So patients are going to be having clinical presentation of fever. They will be having malaise. There is going to be presence of a cardiac auscultation finding, which is going to be given the name of tumor plop. Fever, malaise, tumor plop is what you need to remember. What was asked to you as a question in the exam in the INI-CT was the name of a syndrome. Name of a syndrome, and that's exactly what we are talking about over here. So when you are talking about name of the syndrome, most of you are aware of the fact that there are 4 components that you're going to be having for this syndrome. N is for nevus, A is for atrial myxoma, M is for mucinosis, E is for excessive endocrine activity. Right? Nevi, atrial myxoma, excessive endocrine activity, and the patients are going to be having the presence of the mucinosis. So nevus, atrial myxoma, excessive endocrine activity, and mucinosis, what you need to remember. Of course, what all of us are aware of is Epstein's anomaly was given as an option. Epstein's anomaly is tricuspid atresia. And this tricuspid atresia is going to be seen in case of babies who are going to born to mothers when they have taken a drug like lithium. Right? When we are talking about rhabdomyoma, they are going to be seen in case of children. Children are going to be, wonderful creatures sent by God because they are not going to be having any discrimination. So they are going to be arising in the ventricle. And please remember the fact that they are going to be having an equal predation for both right as well as left ventricle. Adults are discriminatory. Children are not. The second thing is children love Spider-Man. So the tumor cells over here are going to be having an appearance. It's going to be given the name of spider cells. This was a mnemonic which was given by, I would request to recall over here, Dr. Vedika Malik, one of the students. If she is still here, then Vedika, this is what I still remember. Rhabdomyoma is a cardiac tumor that is seen in case of children that is arising from ventricle. The tumor cells in this particular cancer is going to be having an appearance which is given the name of spider cell appearance. Fifth one that you need to remember over here is that whenever we're going to be talking about rhabdomyoma, it is having an association with a condition that is given the name of tuberous sclerosis. Associated with tuberous sclerosis. Right? So 3 tumors that you need to remember so far as the heart is concerned, very, very important. Commonest cardiac tumor is metastasis. Whenever we're going to be talking about the presence of myxoma, it is arising on the atrium, especially the left atrium. Myxoma is going to be having a specific location that is fossa ovalis. Myxoma is associated with a syndrome that is given the name of Name syndrome. Rhabdomyoma is a tumor of children. It's a cardiac tumor of children. It arises from the ventricle. It can be seen equally in both right as well as left ventricle. and it is going to be having an association with a disease that is given the name of tuberous sclerosis. Finally, if you're going to be looking at the tumor cells over here, the tumor cells over here in case of rhabdomyoma are going to be having the presence of projections from the nucleus going towards the periphery or the membrane. This is what is going to be given the name of spider cell appearance. Spider cell appearance. So these are the two examples of tumors about which we need to have an idea so far as atrial myxoma and rhabdomyoma is concerned. Right. So those are the questions which are asked in the exam with regards to the cardiovascular system. If I just have to recall that for you, you got a question in the exam on bulky vegetations, which was an infective endocarditis vegetation question. You got a question in the exam, small cell vegetations, but having endocarditis, merantic endocarditis. You got a question in the exam on early diagnostic marker for heart attack, which was ischemia modified albumin. You got a question in the exam on flipping of the ratio, which was in association with LDH. You got a question in the exam when we are talking about, this is the last one that you're talking about as of now. You got a question in the INA exam that was on the name syndrome, right? So these were the questions. And of course, you got a question on the cardiomyopathy, which was on HOCM, right? That's what you need to remember over here. So after coming back from the meal break, then we are going to be having a discussion about the different types of vascular disorders. And of course, that is going to be the first disorder that we're going to be talking about. So it's almost like 9:16 as of now by my watch. And let's start at the right time. Hopefully, keeping my fingers crossed, 9:50. Right? So that is going to be good enough time. The earlier we start, the sooner is the probability of we finishing it in time, right? हाँ जी नहीं म्याऊ नहीं है अभी तक खुद ही कह लेते हैं म्याऊ 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 इफ दैट हेल्प्स यू रिमेंबर द एग्जाम है ना कैट स्क्रैच डिजीज कॉजेटिव ऑर्गेनिज्म बार्ट थोड़ी ना होता है बार्टोनेला कौन सा बार्टोनेला कुंटाना कॉजेस बार्टोनेला कुंटाना कॉजेस यहाँ पे फंस जाओगे सारे ट्रेंच फीवर और बार्टोनेला हेंजिया इज रिस्पॉन्सिबल फॉर कॉजिंग कैट स्क्रैच डिजीज है ना तो कैट से याद रखना राइट सी यू सून हैव योर मील्स कम बैक
आ गए कि